Hello again to everybody out there in IH704 land, and welcome to the third video podcast for the introductory class. This time, we're focusing on the supply of health services. I'm going to talk about what drives the supply of services. Do I hear anyone saying, "What a dumb question. You've already told us that supply should respond to need," as defined in the previous talk, and I totally agree with you. It should respond to need. However, I talked about the fact that in healthcare, people often demand things that they don't need. And unfortunately, the supply of services more often responds to demand than it does to need. A good example of this can be found in the treatment of diarrhea. We know from decades of research and clinical practice that 95% of diarrhea cases in children are caused by a virus and need to be treated with oral rehydration solution and nothing else. However, parents don't believe that sugar and salt solution is proper medicine and demand antibiotics, and in Africa, particularly injections. Unfortunately, even the best educated health providers often respond to this demand. In a study we did in South Africa a few years ago, even though 100% of care providers knew how to treat diarrhea, only 40% of children with diarrhea were treated with oral rehydration solution, while 60% were treated with antibiotics. In some ways, this could be interpreted as a rational response by healthcare providers faced by insistent parents and patients. The big problem is that sometimes the supply of services responds to neither need, nor demand. And that's what I want to explore. I'm going to cover 10 areas that affect supply. These are listed here. And as you can see, some were already touched on in the talk on the economics of supply and demand. Firstly then, we'll look at ownership and incentives and how they affect supply. We already know that healthcare is not a perfect market. We have information inequalities leading to the principal agent problem, which is often demonstrated through such abnormalities as having physicians' offices which also dispense medicines. In the US, this is often seen in the case of laboratories. This results in the number of tests greatly increasing when the physician owns a laboratory. In addition, we note that if we try and control prices, care providers have a tendency to want to maintain their income. So as the price for an individual service goes down, the volume of the service delivered goes up. The total cost remains the same. All this comes under the rubric of supply-induced demand. Secondly, culture plays a big effect on the supply of services. We can see this on the two sides of the Atlantic based on attitudes to healthcare. In the US, we take the attitude of, if we can possibly do something, we must do it. It's a war against disease. Shoot first, ask questions later. On the other hand, in the United Kingdom, it's much more of a watch and wait approach. See what's happening, and then intervene as appropriate, and if necessary. And of course, in many low-income countries, where there are few options, there's often a very fatalistic view. These views are also largely shaped by our cultural concepts of what diseases are and how we get sick, and also what one's expectations are about what it means to be healthy. The speed of benefit from a particular service often influences supply. We see that the most proven, cost-effective interventions such as prevention form a tiny proportion of the total service delivery package, whereas highly ineffective and often completely unproven treatments make up the bulk of services, to the extent that in the US only 3% of the total healthcare budget is for prevention. As we will learn when we talk about health reform in the United States, Obamacare attempted to correct this balance by greatly increasing the proportion of the federal healthcare budget going to prevention. But in the course of negotiations, the opposition party labelled prevention as slush money, and the fund was largely removed from the federal budget. Advertising plays a huge role in supply. Most of you will be familiar with the vast amount of money drug companies invest in persuading doctors to use the latest and most expensive versions of their products. In the past, this used to be by buying them large gifts or paying for vacations, often in the guise of conferences in Aruba and the like. Tighter regulations have cut that down, but drug company influence on supply still remains a major issue. Of course, we've all seen the Viagra ads on TV, and who wouldn't start to question their own or their partner's virility in the evidence of such powerful advertising? Then CNS or PBS can also greatly affect demand. I recently heard an article on PBS which highlighted the effectiveness of a drug that can prevent prostate cancer, and we can be sure that that article will have a profound effect on people's demands for that drug. And then fiction can also significantly affect the supply, the so-called ER effect. Even when it bears little resemblance to reality, people believe what they see on television, film, or print. We all know that the level of education of individuals or a population affects their overall health status. But education can also affect health services. And intimately related to education is the fact that education can usually correlate to higher levels of income. Higher levels of income mean more disposable income with which to purchase services, more tax income for the society with which to provide services, and as we will also talk about later, more social insurance money to make services available. Technology advancement in health greatly affects supply. In most societies, expensive, gleaming machines are deemed to be better than old tech. Therefore, a CAT scan or an MRI is often the first option, even when a simple X-ray will suffice. And I've already touched on the issues of vaccination and ORS. You need to remember that technology is not limited to machines, but can refer to drugs and clinical interventions as well. As we bring in the more expensive technology, we run into the issues of rationing. For example, do we make the technology available to everybody? And if it's too expensive, who gets it? And what criteria do we use? We will talk a lot about accessibility during this semester, and particularly barriers to access. Obvious barriers include the distance from care providers or facilities, the cost of services, cultural beliefs that may stop people from seeking services, and sometimes simply the opportunity cost of accessing services. This is particularly true in the urban versus rural mix, specialists all tending to congregate in urban areas. But for a rural person to get there, especially in a developing country, they may have to take one or more days off work. In an environment of poverty, the opportunity cost of a lost day of wages may make the service completely inaccessible. There are also some perverse incentives related to access. For example, it was noted that the rate of hospitalization increases in direct proportion to the number of beds available in a hospital or community, a phenomenon called Romer's Law. And of course, there's the hammer and nail effect. If all we have is hammers, then everything looks like a nail. So if we train all our obstetricians to believe that C-sections are the peak of obstetric practice, then every labour is an opportunity for a C-section. As we move down our list, financing is a key aspect of the supply of services. If we don't have the money to provide services, then they can't be made available. We're familiar with some ways that services are paid for. For example, we might pay a doctor a salary, as is done in many health maintenance organizations or in government systems. We might do a straight fee for service. I have a broken leg, you fix uncomplicated broken legs for $8,000 and complicated ones for $10,000. Capitated services are a form of payment that encourages providers to keep costs and quantity of services down. A fixed amount is paid per patient, per provider, per year. If you spend less than that, you make a profit. If you spend exactly that amount, you cover your costs, and if you overspend, you lose money. And of course, these different methods can be combined to produce some sort of mixed method of payment. Patients, of course, pay either directly, such as fee-for-service, or indirectly through taxes or insurance costs. In most cases, though, societies recognize that some individuals have higher needs at different times than others. And so instead of the sickest paying the most, and therefore going bankrupt, we introduce something called risk pooling, where you can draw on the pool when you're sick and pay in when you're healthy. We should note, of course, that the US is one country where until health reform, risk pooling was relatively ineffective, and lack of access because of costs and medical bankruptcy are very common. Finally, legal issues significantly affect the supply of services. To begin with, we set standards that dictate the quality of services. This is seen most commonly in activities such as licensing of care providers and accreditation of facilities. This is a good thing and generally well-intentioned. It controls the supply in such a way that poorer quality services are eliminated. However, in many countries, the nature of services delivered is highly dependent upon the likelihood of law cases. In the litigious US, doctors routinely practice defensive medicine, ordering unnecessary tests and procedures just in case someone says they should have done it in a court of law. And of course, that demand versus need issue comes back to play when patients expect referrals to a specialist as part of what they perceive as good quality care, even if they don't need it. Gatekeepers in a litigious environment and unsure of their own specialized skills often make the referral, even though they're quite capable of providing the service themselves at high quality. So, I hope you've had a chance to prepare for the first class. Veronica and I are looking forward to this semester, and we haven't moved to China. We're going to be right there in class on the first day. Take care now. Bye-bye.